Okay, so let's jump into protocol 5D here. It's bradycardia for adult and pediatric. Just simple little refresher. Remember, bradycardia is slow, tachycardia is fast. So for bradycardia, these are going to be your slower heart rates. And you got your treatment priorities box over here on the left side. It's the yellow box. It's got 4 things: vital signs, IV access, analyze rhythm, and then your rhythm specific treatment. As far as emergency dispatch, EMR, EMT, intermediate, advanced, your treatment for this compared to ACS is no different. It's going to be the exact same. So I'm not going to read all those off again because it does not change at all. Where it starts to change is going to be for the paramedic. If you look over here, there's another yellow box right next to the paramedic before it starts this flow chart, and it says unstable symptomatic bradycardia is defined by any of the following symptoms: dyspnea, shortness of breath, same thing, chest pain, weakness, altered mental status, hypoxemia, or pulmonary edema. So if it has any of those 6 things, they are considered symptomatic if they have the presenting bradycardic rhythm. The bradycardic rhythms can be a sinus bradycardia. It can be a first-degree AV block. It can be a second-degree AV block type 1, also known as Winky block, second-degree AV block type 2, or a third-degree AV block, which is your complete heart block. If you struggle with heart blocks, please reach out to me or Jake or anybody in EMS. We have plenty of things that can help you. They can be confusing, especially if you haven't looked at them in a long time. The best thing you can do is print out a rhythm strip, print it out for, 7, 8, 9, 10 seconds, however long, and then just look at your P waves. If you look at your P waves, that's going to dictate what type of heart block it is. So for a first degree type 1, just a first degree AV block, your P wave is just going to have a little bit of a space between the complex, the QRS complex. But if you look at the next one, it's going to be in the exact same spot. It doesn't get longer, it doesn't get shorter, it stays in that same spot. It's just a little delayed before that QRS complex pops up. If you look at a second degree AV block type 1, which is your Winky block, which is the phrase that people learn in school, or what I'm trying to think what it is, I can't even remember, but it's like space, drop, you got a Winky block, whatever it is. So you have your Winky block is you have, a little bit of space between the complex, and it grows, and then it grows a little bit more, and then it's gone. So that's your P wave. For a second degree type 2 heart block, you're going to have that drop, but your P wave is going to be consistent in every single one. So you'll have a P wave QRS complex, P wave QRS complex, P wave QRS complex, and then you'll just have a drop where there's not going to be anything. And so that's your second degree type 2. Your third degree AV block, your complete heart block, your P waves are just going to be disassociated. So they're going to be all over the place. They're not going to be in the same spot. They'll be before, after, hidden, whatever the case may be. There's no association within those heart blocks. So again, if those confuse you, it's very hard to teach this on a video without being able to draw on the board. Feel free to reach out to me or Jake or anybody at EMS, and we can definitely get you some videos or some practice rhythm strips or anything like that to practice. So we'll start with the sinus bradycardia first degree AV block or the second degree AV block type 1. Your first degree AV block, again, and your second degree type 1 are low degree heart blocks. So you're going to treat those as it's just a sinus bradycardic rhythm. Your second degree type 2 and your third degree AV blocks will not be fixed with atropine. So we're going to treat those as high degree heart blocks, if that makes sense. So if you go to the sinus brady first degree, second degree type 1 box, it has an arrow and it goes straight down to this middle big box. If it's an adult or pediatric and they're asymptomatic, you're going to use the monitor only. You'll treat if symptomatic and the systolic blood pressure is less than 100. For pediatrics, it's less than 70 plus 2 times age in years, as it has been in the several of the past protocols that we've already gone over. So for adults in ACS, treat per protocol 5C, acute coronary syndrome, and avoid atropine if the heart rate is greater than 40 beats per minute. So If it's ACS and your heart rate is above 40 beats per minute, we're going to try to avoid atropine. Not try, we will avoid atropine because we don't need to give atropine for that heart rate. Now, if you go down one line, it says for non-ACS, atropine can be given for 0.5 milligrams IV push, IO push, and you can repeat every 5 minutes to a cumulative of 3 milligrams. So don't give any more than 3 milligrams of atropine. For pediatrics, you'll start with epinephrine, and it's going to be 0.01 mg per kg IV IO push. It's 1 to 10,000, 0.1 milliliters per kilogram IV push or IO push, and you can repeat once. If this pediatric is unresponsive to epinephrine, you can move then to atropine. And the dose for that's going to be 0.02 mg per kg IV push, IO push. It's a minimum dose of 0.1 milligrams, a max single dose of 0.5 milligrams. Easy way to remember pediatric max single doses, it's always going to be your initial dose of your adult patient. So your initial dose for adult is 0.5. For pediatric, your max single dose is going to be 0.5. Again, with pediatrics, just use hand heavy. It'll tell you exactly how much to use. With that atropine dose for pediatrics, you've already given epi, then you just gave your first of atropine. You can repeat the atropine dose one time. So then we go to the high degree heart blocks, which is your second degree, type 2, and third degree, like we talked about. And we go down to that very bottom box. So asymptomatic, monitor and place the pacing pads. For adults, ACS, treat per protocol 5C, acute coronary syndrome, and pace at 60 beats per minute instead of atropine use. Atropine will not be effective in type 2 or second degree type 2 or third degree AV blocks. So we're not going to use it. We're going to pace them. If it's a non-ACS patient, we're going to pace at 60 beats per minute instead of atropine use. And for pediatrics, it just says place the pacer pads and consult online medical control. So we're not going to pace a pediatric patient until we contact online medical control. We'll talk a little bit more about pacing on how to set it up and how to do it a little bit further on in this section. But this is just the top water bradycardia protocols. So any questions on this, again, feel free to reach out. The big keys on this is just knowing your low degree heart blocks versus your high degree heart blocks and treating if the blood pressure is below 100. And then remembering that if it's ACS and their heart rate's above 40, we do not want to give atropine. So that should be it with this protocol, and we'll keep on moving.